Okay, once again, we're going to move down towards the colon and talk about functional lower GI abstracts. And Andrea Shin, who's assistant professor of medicine and microbiology and immunology at IU, is going to join us once again. Andrea.
Great. So that was a really great overview of upper gut motility and FGI or DGBI disorders. So I'll take us downstream. Today, sorry, is my, okay. So for today's abstract review, I'm just going to be focusing on some of the more notable abstracts from this year. And like I mentioned, we'll be discussing more of the lower disorders or the functional bowel disorders, and I'll try to really highlight the key findings. I did try to focus on abstracts that I thought may be more clinically relevant, and then one abstract that I thought was interesting because it does provide novel information. Okay. So the first abstract entitled Effect of the Administration of a Combination of trimebutine, simethicone, and alpha-galactosidase over gas production related symptoms in patients with functional abdominal bloating under a high FODMAP diet. So alpha-galactosidase is an enzyme that has amylase-like activity. It can break down fructans and galacto-oligosaccharides in the small intestine before they enter the colon for fermentation. And it's thought that it may facilitate intestinal absorption and reduce gas production in the colon. There is some data suggesting that it can decrease symptoms related to gas production in the pediatric populations. But in one pilot study, there was no clear evidence for superiority using this agent compared to placebo in adults with IBS. However, the effect of this agent in combination with other antispasmodics or anti-flatulent medications in adults with functional abdominal bloating have not been studied. So in this trial, the investigators set out to examine the effect of a combination therapy, trimebutine, simethicone, and alpha-galactosidase on symptoms of excessive gas production related in patients with functional abdominal bloating. So this was a trial that involved 15 healthy controls and 30 patients who had met symptom criteria for functional abdominal bloating. It was the double-blind, placebo-controlled crossover study. And this is essentially just a diagram that illustrates the study design. So at baseline, they assessed the frequency and intensity of GI symptoms, bowel movements, and they also measured abdominal perimeter before and during meals. And then 1 week later, they put all of their volunteers on a high FODMAP diet and repeated these assessments. And then they assigned patients randomly to treatment with either active therapy or placebo that was to be taken with the first bites of 3 study-specific meals. And they assessed symptoms postprandially about 2 hours after meal intake. And then they then underwent a 1 week washout period, and participants crossed over to the alternate arm, and GI symptoms and abdominal perimeter were again assessed. So this is the figure that summarizes the overall findings of the study. So here on the left of the table, I'm having trouble controlling my mouse. On the left is the healthy control data. And what you can see here is that with the high FODMAP diet, there were measurable increases in the abdominal perimeter, belching, and flatulence. When they combined hot fat FODMAP diet with the active treatment, this helped to prevent that increase in abdominal perimeter distension and pain intensity, as well as flatulence. And similarly, in the FAB group, or the functional abdominal bloating group, the diet did expectedly produce symptoms of flatulence, belching, and then use of the active treatment with the high FODMAP diet decreased the intensity of distension and pain, as well as the number of belches. And they also compared the active treatment or the magnitude of change with the treatment versus placebo, and compared to placebo, the magnitude of pain reduction, belching, and number of bowel movements was also significantly lower with the active treatment compared to the placebo treatment. In the functional abdominal bloating group, 94% on active treatment reported global improvement over 44% with placebo. And this is a figure that pretty much illustrates those findings. And so you can see here, you start with baseline, and then with a high FODMAP diet, there's increase in pain intensity and increase in bloating. And then in the pink bars, that is the high FODMAP diet with the active treatment. This reduced the increased intensity of pain and in bloating. And that's also significantly different when compared to the placebo, which is shown in the dark blue. So the conclusions from this study were that high FODMAP diet does trigger gas-related symptoms in both healthy controls and in the patient group. Alpha-galactosidase, when combined with trimethoprim and simethicone and taken with a high FODMAP meal, was indeed superior to placebo in reducing some symptoms. So the takeaway was that this could potentially represent a novel therapy for patients who are consuming a high FODMAP diet or perhaps do not want to be on restrictive diet. And these were just my impressions of overall strengths and limitations. I thought that major strengths of this study are that there really are very limited clinical trial data in this patient subgroup of people who suffer from functional abdominal bloating and distension, which is a really problematic symptom for many patients. I like the fact that the trial also focused on gas and bloating related endpoints, which are usually not primary endpoints in most of the clinical trials in patients with lower FGIDs. And then they specifically examined the efficacy of their treatment on a high FODMAP diet, which I think is also important considering that not all patients will be able to adhere to restrictive diets long-term, or even if FODMAPs do aggravate symptoms, adherence to diet therapy and the long-term benefit of the therapy is sometimes questionable. The limitations are, again, the small study size. This was a limited follow-up, and it is a crossover study, so there's always a potential for crossover effect. And of course, it was the combined therapy, so we can't really measure the effect of the individual treatment of alpha-galactosidase because it was used in conjunction with antispasmodics and anti-flatulent therapy. The next abstract that I wanted to highlight was a randomized double-blind placebo-controlled study assessing the effects, tolerability, and safety of Enteris gel for the treatment of IBS-D. So Enteris gel is an intestinal adsorbent. It is available over the counter. You can actually buy it on Amazon, and this is a picture from the Amazon website. It's an adsorbent that can bind large molecules in the gut, including bile acids or bacterial toxins, and it has been proposed that it could be used for the treatment of acute and chronic diarrhea. So the aim of this study was to evaluate the treatment efficacy of Enteris gel versus placebo in patients with IBS-D. This study recruited participants ages 16 to 75 with IBS-D for a randomized double-blind placebo-controlled trial. And I just included a diagram that shows the general study flow for this trial. The study was conducted across 28 sites in England, and it was co-designed with both patient and public involvement, and also involved in-person and virtual study participation because it did start before the pandemic and carried on after the pandemic. So participants recorded their symptoms using daily e-diaries and questionnaires. The primary endpoint was the percentage of responders, and response was defined using a composite outcome of abdominal pain and stool consistency during at least 4 of the 8-week double-blind trial. And so this is based on FDA guidance, and their estimated sample size was 430. So from a period of about 2018 to fall of 2021, they screened 647 subjects and 440 were randomized. They conducted both intention to treat and per protocol analyses. And when they completed the study and analyzed their data, they did observe that Enteris gel was associated with significantly higher response rates for the overall response, as well as for individual symptoms such as stool consistency and abdominal pain, which is shown in this table here. And the per protocol analysis, when they limited to the observed data only, showed, again, comparable results. They did also note that their virtual recruitment and retention was very good, and they actually had more recruitment and more retention using the virtual platform. So the conclusion from this trial was that Enteris gel may be an effective therapy for short-term reductions in stool consistency and abdominal pain in IBSD. The major strengths that I felt of the study were that it was a very large sample. They did use validated criteria to define their study population, and they tried to frame their trial around FDA responder endpoints. Major limitations include, of course, this is a shorter duration of follow-up, so 8 weeks versus the standard 12. There is a potential for interaction with other pharmaceutical drugs because Enteris gel is an intestinal adsorbent. And they did not specifically select or identify patients with bile acid malabsorption, which could potentially also explain some of the treatment efficacy. The next abstract that I want to highlight that I think is really interesting, I think has probably gotten a lot of press already, is this abstract on the Vibrant capsule. So this was a phase 3 trial examining efficacy and safety of the Vibrant capsule for chronic idiopathic constipation. So chronic constipation is a very common disorder, but a large proportion of patients remain dissatisfied with their current treatment options. Vibrant capsule is an orally ingestible, programmable capsule, and it is felt to augment circadian rhythm and can increase stool frequency. So the aim of this trial was to conduct a study evaluating the efficacy and safety of the Vibrant capsule in patients with chronic idiopathic constipation. So they enrolled patients with CIC using the modified Rome-3 criteria. This was a multi-center, double-blind, randomized, placebo-controlled trial. And participants were randomized to either the capsule or to placebo to be taken 5 times per week for a study duration of 8 weeks. And the Vibrant capsule was programmed after it was delivered, ingested to deliver 2 vibration sessions each that occurred over the course of several hours. And then they did capture symptoms using electronic stool diaries, assessing stool frequency and other constipation symptoms. So the primary outcomes, and I apologize, missed the number here, but the primary outcomes was percent of participants with an increase of at least 1 complete spontaneous bowel movement per week, or the proportion of participants with an increase of at least 2 spontaneous bowel movements per week over 6 of 8 weeks. And then they did assess other bowel symptoms, and they conducted an intention to treat analysis and monitored their adverse events. They recruited and enrolled a total of 349 patients, 85% of whom were female. 200 were randomized to the capsule and 149 to placebo, and there were no major baseline differences in the demographics between the 2 treatment groups. And this is a figure showing their major endpoints. And so as you can see here, there was a significantly greater proportion of individuals who responded in terms of the complete spontaneous bowel movements, 1 per week or 2 per week, in those who were assigned to the Vibrant capsule compared to placebo. They did note that significant increases in that complete spontaneous bowel movement rate were seen within the 3rd week of the study and peaked by week 6 and then were durable for the duration of the trial. This is a table that shows their secondary outcomes. And again, what was shown here was that the Vibrant capsule did significantly improve several secondary outcomes, including straining score, stool consistency, and quality of life. There were no significant differences in bloating scores. They did, as I had mentioned, record adverse events, which were reported in about 6.5% of those assigned to the capsule and 9.4% assigned to placebo. 2 participants with Vibrant capsule actually reported diarrhea, but there were no serious adverse events. So in conclusion, Vibrant capsule, based on the study, appeared to improve stool frequency as well as other bowel and abdominal symptoms and quality of life in patients with chronic idiopathic constipation. And these benefits were seen fairly soon after the initiation of therapy and were sustained. There were no major significant adverse events, and the findings suggested that this capsule could represent a novel, non-pharmacological intraluminal therapy, which is effective, safe, and well tolerated. Major strengths of the study include its large multi-center design. It was a randomized trial, had a very rigorously designed framework, and it did explore multiple primary and secondary endpoints. The limitations, which are common in these types of trials, that was a mostly female population. It did have limited treatment duration, so it was studied for only 8 weeks, and so longer term follow-up data are needed. As with any of these ingestible capsules, there's always a potential for capsule retention in certain individuals. But overall, I think the data are very promising, and it could represent, again, a novel therapy for chronic constipation. The next abstract that I wanted to bring some attention to was tenapanor, just because I thought this data was interesting. Many may be aware tenapanor is now FDA approved for the treatment of IBS-C. This was an abstract that looked at the long-term treatment of tenapanor on symptoms of abdominal pain as well as other abdominal symptoms. So tenapanor, just as a refresher, is a minimally absorbed small molecule inhibitor of intestinal sodium hydrogen exchanger. And it is thought to also reduce abdominal pain by inhibiting TRPV channels, which are nociceptors, TRPV signaling within the gut, and potentially by reducing intestinal permeability as well. So this abstract presented a post-hoc data analysis that looked at the abdominal symptoms that were reported during the TEMPO-TRUE trial, which was a phase 3 study of tenapanor in IBS-C. In the original clinical trial, participants included men and women ages 18 to 75 with IBS-C. According to Rome 3 criteria, it was a multi-center phase 3 trial, randomized double-blind placebo-controlled study. The study design included a 2-week screening period followed by randomization to either tenapanor or placebo treatment for a total duration of 26 weeks. And the outcome data specifically for this analysis was abdominal symptoms, including pain, bloating, discomfort, cramping, and fullness, using a 0 to 10 point scale. So the original study population did include 293 participants who were randomized to tenapanor and 300 who were randomized to placebo, and baseline characteristics were similar between the groups. And so this is the results of the long-term data analysis. And essentially what they're showing here is that the average weekly scores for abdominal pain, discomfort, bloating, cramping, fullness, all of these decreased significantly from baseline to week 26 in the patients with IBS-C. They also looked at the difference between the change for treatment versus placebo at this long-term follow-up period. And they observed that there were significant differences in the change in symptoms that are shown here on the far right of the table, denoted in gray. So again, this was a post-hoc analysis of previously collected data, but what it does go to show is that tenapanor appears to improve multiple abdominal symptoms in patients with IBS-C, included that were assessed in a long-term follow-up of 26 weeks. Major study strengths, again, very large trial, methodologically rigorous, was multi-center and did use, again, validated Rome criteria to try to capture the study population. This was a post-hoc analysis, and it is also mentioned when you review the original clinical trial that patients were selected based on their spontaneous bowel movement and complete spontaneous bowel movement frequency at baseline. So this may not necessarily be generalizable across all patients with all differing levels of IBS-C severity. This was an abstract that was presented as a poster, and the reason I wanted to include this, I thought that this again provided some clinically useful information about, what is the long-term outcome of patients. This was a study examining the long-term outcome of anorectal biofeedback in patients with dysenergic defecation. Anorectal biofeedback has been shown to be superior over non-biofeedback treatment for dysenergic defecation. Unfortunately, we don't really know how effective it is in the long term. So this study sought to describe the long-term clinical profile and quality of life with patients with dyssynergic defecation who were treated with biofeedback. This was an observational study of consecutive patients who had previously completed a 6-week course of manometry-based biofeedback. And participants were asked to complete questionnaires that were implemented at various time points. So immediately after biofeedback, which was their short-term follow-up, 8 months after biofeedback, which was their medium-term follow-up, and then 8 years after biofeedback, which was long-term. And the questionnaires included questionnaires on constipation scores, hospital anxiety and depression, quality of life scores, and questionnaires asking them about satisfaction and control over bowel movements. So a total of 72 of 126 patients were recruited. And by the end of this follow-up period, 58 responded. Ultimately, 5 did require surgery, and most did say that they would recommend biofeedback for others. They did show, based on their data, that short-term follow-up revealed significant improvements in constipation score, satisfaction, control over bowel movements, and quality of life. At medium and long-term follow-up, the overall cohort had sustained improvements in satisfaction, control, and quality of life, and anxiety scores were also improved in the long term. What's notable here was that constipation scores remained lower at the medium-term follow-up, but not at the long-term follow-up. They did note that short-term improvements in patient satisfaction and short-term improvements in control were also correlated with long-term improvements in control and satisfaction, as well as long-term improvement in constipation score. So these data suggest that anorectal biofeedback does lead to sustained long-term improvements, and the short-term response seems to predict how well they will do in the long term, and could also help identify patients who would be more or less likely to respond to refresher courses or supplemental therapy. I thought that the multiple time points were were major strengths of the study. They did use standardized questionnaire, and they do have very long-term outcome data. Some limitations were that they didn't really capture other baseline predictors that might determine their long-term outcomes. And there is always the possibility of potential selection and responder bias with these types of studies and how generalizable these findings can be. The last abstract that I wanted to just discuss was more of a novel pathophysiologically oriented abstract, and perhaps a tool as a possible biomarker in the future. This was a study published by Hans Tornblom and Magnus Simron's group, and it was a study of fecal metabolite profiles in predicting responses to gluten-free diet and IBS. So there is data suggesting that a gluten-free diet can reduce symptoms in some patients with IBS. And the aim of this study was to compare the effect of a gluten-free diet and also assess fecal metabolites in IBS and healthy controls, and try to identify predictors of clinical response by examining fecal metabolites. So this was a randomized placebo-controlled crossover study of IBS patients and healthy subjects who followed 2 14-day gluten-free periods. And during these periods, they were assigned to either placebo or gluten powder. And this was separated by a washout period at 14 days. IBS participants reported their symptoms according to the IBS SSS and stool form using the Bristol stool form scale. They defined true responders as those who had a decrease in their IBS SSS of at least 50 only after the gluten-free period. And they collected fecal samples before and after the diet periods, and then measured fecal metabolites. And then they conducted some data analyses using a principal component analysis, and then orthogonal partial least squares discriminant analysis for modeling. This is a figure of some of their main findings. What you see here on the left is, these are all their different symptoms. So they measured a change in abdominal symptom severity, change in abdominal pain, change in a stool consistency. And this is either before the gluten-free and after the gluten-free period, or before gluten, after gluten. And they did note that symptom severity and pain intensity in particular improved after the gluten-free period. And you can see that these are kind of these paired changes. What they didn't see was that there were not any significant differences between the two periods themselves. So there was no change in the delta with the exception of stool consistency. Stool consistency did differ between the two periods with less stools during the gluten-free period. Now, when they looked at their fecal metabolite data, they did see that using their principal component analysis plots, that the gluten-free diet did have different effects on the fecal, or did have different effects on the fecal metabolites of IBS patients and healthy controls. And you can see that in the top left-hand corner that they are separated. And then when they used their modeling, they did observe that using these fecal metabolites, they could actually separate IBS patients and healthy subjects based on the change in their fecal metabolite profiles. They then went on to examine if the profile could predict a response to gluten-free diet. So they analyzed their data from the IBS true responders and the non-responders. And so on the bottom left-hand corner here, you can see that the PCO8 plot shows that the two groups could be separated. And again, the modeling could predict and separate those who would be true responders versus non-responders. So in conclusion, symptoms reduced gluten-free, some symptoms were reduced by gluten-free diet in patients with IBS, and these responses appeared to be predictable by the fecal metabolite profile. And the gluten-free diet did have different effects on the fecal metabolites in IBS participants versus healthy volunteers, suggesting potential important interactions between food components and gut microbial metabolisms. I thought this was a very carefully controlled diet intervention study. I like that they included both IBS and healthy subjects and had a moderate sample size for this type of study design. There's always a potential for order effect with crossover studies. Individual metabolites weren't assessed. So again, this is more of a sum of metabolites. There was no differences between the different treatment periods, especially for IBS, SSS, and abdominal pain. So in summary, today, I covered some abstracts that discuss novel therapies for IBS-D, functional abdominal bloating, chronic constipation, also examined long-term outcomes for current treatments, including tenapanor and anorectal biofeedback for IBS-C and dyssynergic defecation. And then lastly, highlighted an abstract studying the gut microbiome or microenvironment in predicting responses to diet-based therapies.